Dr. Casale, I just wanted to let you know that you're muted currently. Dr. Casale, are you able to hear me?
Actual disease that is going on, then that helps you with picking the right agent. So let's talk a little bit about the problem. But before we do that, we'll start with a pretest polling question to just gauge your knowledge about some of the important things that we will discuss today. So the first question is, the primary cytokines involved in type 2 inflammation, the most common endotype in patients with chronic rhinosinusitis with nasal polyps are, and just click on whichever ones you think are most important for this particular disease. All right, so let's go on to the next question. Which biologic showed improvement in nasal polyp scores by more than 2 points in close to half the patient population at weeks 24 and 52? And the choices are benralizumab, depilomab, mepolizumab, and omalizumab. And we're talking about the phase 3 trial data, which has just been published for benralizumab. So all 4 of them have publications of their phase 3 data. All right, let's go on to the next. Which is the most commonly observed treatment emergent adverse event across clinical trials of all biologics studied for CRS with nasal polyps? Epistaxis, injection site reactions, nasopharyngitis, or abdominal pain? Okay, so like the other questions, we have a mix of answers, and hopefully as we go through the presentation, we'll be able to pick out the most appropriate answer. Next, please. So we're going to start with a case here, and we want to ask you a question about this. So this is Mr. Brown, a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps. He returns 12 months after endoscopic surgery, complaining of persistent symptoms. You suspect nasal polyps have regrown, as type 2 inflammation is a predictor of polyp return in more than 50% of cases. Disease scoring systems show some improvement, but don't meet euphoria criteria for adequate response. What does euphoria recommend now? So the answers are return to medical management in a short course of oral corticosteroids, try a biologic or revision surgery, an exhalation delivery system with fluticasone, or a corticosteroid-eluting implantable stent. All right, let's go on to the next. So feeling discouraged, he says if the nasal polyps are just going to grow back anyway, he doesn't want to go through all the expense, pain, and downtime of undergoing surgery again. Shared decision-making means the best action now would be to what? Advise him to reconsider surgery because more than 30% of patients do require repeat operations. Apprise him of the guidelines recommended and ask him to decide between two options. Give him information about all available biologics. Ask him to choose one. And let him know all his therapeutic options and the pros and cons of each. All right, let's go on to the next. So now we're going to talk a little bit about Bob. Bob's a 45-year-old man with chronic rhinosinusitis with nasal polyps. The asthma comorbidity is present, which is common, right? And he complains of polyps that have gotten worse over the last 2 years. He's required multiple oral corticosteroid bursts within the last 2 years. And you feel that he's compliant with his medications, which include saline irrigation and intranasal corticosteroids. But his quality of sleep, his work productivity, social life have all been negatively affected by the disease. And he's never had surgery. So what additional information do you think would be most important at this point? So a blood eosinophil count and serum IgE, CT scan of the sinuses, nasal endoscopy, spirometry, or pheno. And in this case, it's not really a polling question, so I want to go through some of the choices. The reason you might get a blood eosinophil count would be if you're considering a biologic to determine whether or not he might have that phenotype driven by eosinophils. Serum IgE can be somewhat helpful, but total IgE is not very helpful. So if it were IgE, for example, the Staph aureus enterotoxin, which can be important in causing chronic rhinosinusitis with nasal polyps, then yes, it might be more important. You clearly need to do some sort of imaging, either a CT of the sinuses or nasal endoscopy. Spirometry might be important as well because we know that patients with nasal polyps and chronic rhinosinusitis tend to have worse courses in their asthma. Pheno would be useful only if you're considering which biologic you might pick to treat both the asthma and the nasal polyps. So let's give a little bit of an overview of the scope of the problem. So in the United States, there's about 29 million people that are diagnosed with chronic rhinosinusitis. Now, the majority of those people do not have nasal polyps, so about 80%. And those individuals are predominantly female. The 20% of patients with nasal polyps are predominantly male, although the split isn't that big of a difference between males and females. But overall, you're talking about a large percentage of the population. So it's a big problem. And it's a problem that is very unique in that it tends to occur more in Western countries. If you look at the map here, certainly the US has the highest prevalence. We're not exactly sure why. Europe is right behind with 11%. China has a pretty high prevalence, but their nasal polyps in Chinese individuals tend to be a little bit different. They tend to be less likely to have a Th2 phenotype. Now, if you have chronic rhinosinusitis with nasal polyps, the cost of caring for a patient tends to go way up. So in this observational study of 21,000 patients, about half had chronic rhinosinusitis with nasal polyps, and the other half were without. And you could see that there's a big expense increase in pharmacy costs, medical costs, office costs, and ambulatory costs, resulting in more than $11,000 in annual medical costs than control patients. So $18,964 is a lot of money when you're looking at a group of individuals that represents about 11% of the United States population. So how do you diagnose this disease and comorbidities that often occur with it? From a clinical perspective, if you're looking at just chronic rhinosinusitis, not with nasal polyps, the definition is you have to have at least 2 of the following symptoms for at least 12 weeks. Mucopurulent drainage, nasal congestion or obstruction, facial pain, pressure or fullness, and a decreased sense of smell. So 2 of those plus 1 objective criteria, that is either endoscopy or sinus CT to document changes consistent with chronic rhinosinusitis. Now, if you have nasal polyps, and you could see that on the both the CT scan and a rhinoscopy view, that tends to involve the ethmoid and maxillary sinuses especially, and you tend to have a little bit difference in the symptoms in compared to patients with chronic rhinosinusitis without nasal polyps. The symptoms completely overlap, but the loss of smell or decrease in smell tends to occur much more frequently if a patient has nasal polyps, whereas facial pain and pressure tends to occur more frequently in patients with chronic rhinosinusitis without nasal polyps. But you could see by the symptom scores, it's somewhat difficult to take this apart, and that's why you have to have some sort of visualization to determine whether or not the patient really does have nasal polyps. Now, if the patient does have nasal polyps, just like with asthma, it's broken up into uncontrolled and severe patients along with controlled. Uncontrolled includes those patients that have persistent or recurring chronic rhinosinusitis despite long-term intranasal corticosteroids and have received at least 1 course of oral corticosteroids in the preceding 2 years. Those patients that have severe disease are individuals that have a nasal polyp score of greater than 4, and I'll cover that. So that goes from 0 to 8. Symptoms despite long-term intranasal corticosteroids with the need for an add-on treatment. And the persistent symptoms that we talked about include loss of smell, congestion, and other symptoms. Now, this particular disorder with nasal polyps is often associated with other comorbidities. So if you have this, you have an increased odd ratio of 78 0.6 for having aspirin or nonsteroidal sensitivity with the so-called triad, Samter's triad, originally called aspirin sensitivity or sensitivity to nasal steroids, nasal polyps, and asthma. You're about 7.5 fold increased risk odds ratio of having asthma, and you could see that you're also much more likely to have allergic rhinitis. Now, in addition to having a higher likelihood of asthma, if you do have asthma and nasal polyps, you tend to be more symptomatic and have a worse prognosis in regards to your asthma. And here you're looking at a table comparing patients with and without nasal polyps that have asthma. And you could see that those with nasal polyps tend to be a little bit older. Their FEV1 values are lower. They tend to have more of a T2 high phenotype as manifested by an increase in sputum or serum eosinophils. They tend to require higher doses of cortical steroids, and they have less control based on symptom scores. And even more importantly, you could see in the bar graph, they tend to have more asthma exacerbations. Now, we mentioned this briefly before, but chronic rhinosinusitis with nasal polyps and aspirin sensitivity. So this occurs in about 30% of patients with nasal polyps and asthma. And these patients tend to be sensitive to all COX-1 inhibitors, but they may, in most cases, able to tolerate COX-2 inhibitors. When you look at those patients, their asthma tends to be more severe than average, more difficult to control. And if they were exposed to a COX-1 inhibitor, very often they get profuse rhinorrhea to start, and then they get intense lower airway mucus production with airway contraction, bronchoconstriction, and wheezing. The nasal polyps with the chronic rhinosinusitis associated with this disorder tends to be more pansinusitis with recurrent eosinophil-rich polyps with a lot of mucus production and a loss or decrease in the ability to smell. Now, just like with asthma, atopic dermatitis, and a number of other diseases, we know there are certain inflammatory endotypes and phenotypes of this disease. And that knowledge, if you're able to figure it out for an individual patient, will likely help you in regards to picking the appropriate therapy. There's 3 broad categories for inflammatory endotypes in chronic rhinosinusitis: type 1, 2, and 3. Type 1 is manifested by having a predominance of CD8 positive T cells, Th1 cells, and ILC1 cells, along with NK cells and macrophages, with the primary cytokines involved including interferon gamma and IL-12. This tends to occur more in females than males. The type 3 is similar to what we see, for example, in neutrophilic asthma. You have more neutrophils with Th17 cells and ILC3 cells with the production of key cytokines of IL-17 and 22. So with type 1 and type 3, unfortunately, we don't have very good biomarkers that we could readily measure as a point of care test. However, type 2 is, like asthma, marked by an increase in eosinophils that you could measure in the blood as well as in nasal secretions. And importantly, it too manifests as a disease where there's a predominance of ILC2 cells, Th2 cells, which activate basophils and mast cells. So the key cytokines in this include IL-4, 5, and 13. And that's why when we talk a little bit later about biologics, they're all aimed at one of those particular cytokines. In addition, the other drug that we use, anti-IgE, is aimed at the product of B cells that is stimulated by Th2 cells. In the presence of IL-4 and IL-13, you switch from making IgM to IgE. Now, the differences between the two main phenotypes, again, one is a Th1-driven disease, less likely to have asthma than the Th2-driven disease, less likely to have allergic rhinitis, and less likely to have aspirin sensitivity. Somewhat complex slide, but just walk you through it. So just like in the lower airways or in many other structures, the epithelium is an active player in the inflammatory pathways that are important to these disorders. So anything like an allergen or a virus or cigarette smoke or certain types of bacteria can trigger the airway epithelium to produce cytokines called alarmins, TSLP, IL-25, and IL-33. Those alarmins are very important because they will take an undifferentiated innate lymphoid cell and turn them into an ILC2 cell, which ultimately then can produce cytokines important for the differentiation of Th cells into Th2 cells. Now, once that happens, Th2 cells produce cytokines like IL-4 and IL-13 that, as I mentioned before, can cause a B cell to switch from making IgM to IgE, and the IgE then binds to mast cells and basophils, and they could be triggered to release their mediators, which include the same cytokines. So you could get a cyclical propagation of this event, if you would. Because these cells, like ILC2 cells, produce cytokines important for mast cells and basophils that release cytokines like IL-5, eosinophils are driven into the airways, in this case, the upper airways. But ILC2 themselves can also make IL-5. And IL-5 is clearly important for eosinophil differentiation and survival. Now, IL-4 and IL-13, not very important chemoattractant agents. IL-13 has some mild effects, but they do upregulate critical adhesion molecules on endothelial cells that, in the presence of IL-5, allow the eosinophils to go between endothelial cells and migrate into the tissue. Furthermore, IL-13 has a number of other effects, and similar to what we talk about in the lower airways, can cause mucus production and fibroblast generation so that you can get fibrosis and polyp formation. So if you look at this scheme, you would think, therefore, that targeting some of these key cytokines would be important as a possible step in treating this disorder. And it's for that reason that we use drugs that block IL-4 and 13, IL-5, and IgE. The alarmins have not yet been studied. Of course, there's recent data on the efficacy of TSLP for the treatment of asthma, but we haven't seen any data on either it or the other two cytokines on treatment of patients with this disorder. So let's return to Bob. So now his FEV1 has dropped a little bit. It's down to 68%, but he's got good reversibility. His FeNO is elevated. It's greater than 20. It's 35. He's not aspirin sensitive. Now, what does that FeNO mean? Probably the important thing about the FeNO, again, is that if you're measuring lower airway FeNO, which, by the way, you can measure upper airway FeNO independently, but lower airway FeNO greater than 20 is elevated, tends to imply that IL-13 could be important in this patient's asthma. Why is that? Because the lower airway epithelial cells, when stimulated by IL-13, can produce inducible nitric oxide. Bob has had 2 oral courses of corticosteroids, and he's already on high-dose ICS and LABA with nasal saline irrigation and intranasal steroids. So what would you recommend for him now? You could do endoscopic sinus surgery, you could do a biologic, you could do EDS with fluticasone, or you could do alternate day oral corticosteroids. And all 4 can be utilized. Now, personally, as we go through the choices, I'll give you my opinion. I would not use alternate day oral corticosteroid just because this is a chronic recurrent problem, and we wouldn't want to have the long-term effects of corticosteroids. But the other 3 options, I think, deserve discussion. So let's talk about the medical management. Saline irrigation provides some benefit, but you have to use high volume, 150 milliliters or greater. Intranasal corticosteroids clearly provide some benefit, but oftentimes not enough for patients with severe nasal polyps. Oral corticosteroids, we may use a short burst of to shrink the polyps down a little bit so that you could get better delivery of the nasal corticosteroids. And also, with the relief of that severe blockage, you might be able to get the patient's ability to smell back towards normal. But all of these tend to have some degree of failure. Now, the other thing you could use is an exhalation delivery system with fluticasone. And as shown in the illustrations, the advantage of this is that you tend to get a much higher delivery of the corticosteroid into the nasal cavity and sinuses than you do with a typical nasal spray. So if you look at the phase 3 data for this, polyps were actually eliminated in about 1/4 of patients on one side by week 24 versus 8.7% in the placebo. SNOT-22 score improved quite a bit, 21 points. The need for surgery decreased by almost 2/3. So that's pretty impressive results. So typically, in my opinion, I usually try this before I consider endoscopic surgery or a biologic, just because it's easier and it's less expensive. And the results can be pretty dramatic for some people. If you are considering endoscopic sinus surgery, there's pros and cons like there are for everything else, right? So you do tend to get more rapid relief of symptoms with a high success rate and typically minimal side effects or complications. Unfortunately, about 40% of patients have regrowth of nasal polyps in 18 months. So once you recover from this, you're still using intranasal corticosteroids. And even with that, you may have regrowth. Type 2 inflammation is a strong predictor of nasal polyp return. But the other thing you have to consider is the skills of the surgeon. So if you have a very skillful surgeon that does this a lot, then this could be a very viable option. But you will have to follow that up with intranasal corticosteroids in close follow-up because they tend to regrow. So we talked about the regrowth and that the numbers suggest that up to a third of patients may require repeat surgery over 12 years, and 20% of patients may require multiple surgeries. Now, that doesn't necessarily mean you shouldn't do surgery, because in some people it's very effective. But when we talk later on about shared decision-making with the patient, I think you have to give them the pros and cons of all the treatments and make a decision together. Another potential option, much less invasive, is a steroid-eluting stent. So basically, an implantable stent can be placed into the ethmoid sinus, and you leave it in place for 90 days. Now, these are impregnated or coated with mometasone and other corticosteroids, and this can be done very easily in the ENT office. Most patients will have significant reductions in obstruction and congestion, with about a 61% reduction in need for revision surgery. So this could be another potential option. What about biologics? Well, the criteria for considering biologic treatment. First off, the patient should have bilateral nasal polyps. Second, if they have a history of surgery, they should meet at least 3 of the below criteria, or if they didn't have a history of surgery, 4 of the 5 criteria. So those include evidence of type 2 inflammation, either through nasal secretions or blood, elevated eosinophils, the need for systemic corticosteroids, significant impairment in quality of life, loss of smell, and the diagnosis of comorbid asthma. These are the 4 biologics that are that have published data, published phase 3 data. The first was Depilomab, and of course, that binds the it's a monoclonal antibody against IL-4 alpha, which is the common receptor chain for both IL-4 and IL-13. And it is dosed at 300 milligrams every 2 weeks and was approved in June of 2019. Omalizumab was the second one approved. And Omalizumab, of course, has been around for a long time. It's an anti-IgE molecule. It's dosed according to IgE and body weight. Mepolizumab was just approved this year, and it's dosed based on a Q4 weekly regimen. And then benralizumab, the phase 3 trial data is in press in JACI, and it's different than mepolizumab in that it binds the IL-5 R alpha receptor, which is present on basophils and eosinophils. And when that binding occurs, it causes ADCC, antibody-dependent cell-mediated cytotoxicity. So as opposed to blocking the effects of IL-5 like mepolizumab or reslizumab, it actually causes those cells to be destroyed. So it's cell depleting. Now, the appropriate treatment and management of nasal polyps requires good visualization in a scoring system so you know what you're up against. This is the typical scoring system, and this is what's reported in the clinical trials that we'll discuss in a minute. So it goes from 0 to 4, with 4 having very large polyps, complete obstruction, and 3 reaching to the lower border of the inferior turbinate, whereas 2 is the lower border of the middle turbinate, and 1 is basically small polyps in the middle meatus. In addition to the nasal polyp score, it's important to get some sort of handle on congestion, which is the major symptoms in these patients. And that's also scored on a 0 to 3 scale from none, mild to moderate to very severe. Keeping that in mind, here are data for Depilomab in their pivotal trial. So they did 2 trials. In one, Sinus 24, patients were treated with Depilomab every 2 weeks. In the other study, Sinus 52, Depilomab was used every 2 weeks until week 24, and then every 4 weeks until week 52. So if you look at the nasal polyp score for Sinus 24, you could see that there's a decrease of about 2. A good response is considered if a patient has a decrease of 1 or greater. Nasal congestion goes down quite a bit. In this case, it's also about 1 in comparison to placebo. And a good improvement is considered greater than 0.5. The thing you can notice from this study, though, is once the patients were taken off Depilomab at week 24, you could see that the nasal polyp score tends to go back up, and the congestion score tends to go back up as well. Sinus 52, also very good response in nasal polyp score and congestion, and it didn't fall off when you change the regimen of Depilomab from every 2 to every 4 weeks. Importantly, there was also a significant reduction of the need for cortical steroid burst or surgery during the trial period with the use of Depilomab. Adverse events for the use of Depilomab was not really different than what we see with asthma, and pretty benign. Now let's turn to Omalizumab. So here we have a 24-week, they had 2 trials, Polyp 1, Polyp 2. Patients are dosed again based on IgE and body weight, and you could see that in regards to improvement in nasal polyp score, you have about a 1 to a little bit greater than 1 improvement in nasal polyp score over placebo. So it met that critical criteria of 1 or greater. As it did with congestion, where you have improvement in nasal congestion greater than 0.5, both at week 16 and 24. Similar to other indications for the use of Omalizumab, no remarkable adverse events that were of note. For that one question, I got it wrong the first time I saw it too. I also put most common adverse event was injection site reaction, but it is actually nasopharyngitis. Mepolizumab. So their data was published in Lancet Respiratory Medicine this year. And when you look at their phase 3 data, you could see that the percentage of people that had 1, 2, 3, 4, or greater than 5-point improvement in nasal polyp scores tended to be greater in the patients treated with Mepo than the patients treated with placebo. There was overall a difference, adjusted difference in medians of about 0.73. Not quite where you would want it, still clinically significant, but not up to that 1 that the recommendations are for improvement in nasal polyps. Now, if you look at nasal congestion, same sort of study. There are people that do very well with MEPO and some that do not quite as well. Their nasal obstruction VAS score did improve to a level that was probably clinically meaningful. So overall, positive trial results for mepolizumab as well. And in their study, they too found a reduction in the need for nasal surgery during the 52 weeks patients were on the trial. Similar to asthma, again, relatively low adverse event profile, no different than what you see in asthma, and pretty safe. Now, what can we say about the three drugs that we talked about? It looks like the Depilomab had the biggest effect, Omalizumab next, then mepolizumab. However, these are not head-to-head trials. There will be a head-to-head trial of Depilomab against Omalizumab shortly going on. So that will maybe help us decide which of either the drugs is better, and is it better for everybody, or is it just going to be better for a certain subpopulation? And if we could recognize who that is, that would be helpful. As I indicated, the benralizumab data was just published in JACI Online. Their improvements in nasal polyp score and nasal congestion did not reach the clinically meaningful levels that I discussed, but they were statistically significantly different than placebo. So stay tuned and we'll see where that goes. So how do you choose a biologic? Well, very carefully, right? So first off, selecting a biologic according to the Euphoria guidelines, confirm the diagnosis. If they do have a comorbidity of asthma, then I think you're much more likely to pick that biologic because their asthma tends to be more severe and you could treat two diseases with the same drug. But you still have to talk to the patient about what's the best option, right? And that really requires an intensive discussion on the pros and cons of each of the therapeutic topics that we've already covered. Now, after 6 months, this is what I was talking about. This is the assessment that should be done after 6 months to determine whether or not the patient had an acceptable response. Nasal congestion decreased by 0.5, nasal polyp score by greater than 1, snot 22 by greater than 9, and VAS total symptom score reduction of greater than 2 centimeters. If they get that, then you would probably consider continuing the biologic. What we don't know is when or if you could stop the biologic. So just like with asthma, you know, people have been on one of the biologics, certain biologics for 3, 5, 10 years. And after that period of time, if you take them off, they still may have a recurrence of symptoms. Because the biologics have not been used that long for nasal polyps, we don't know how long you would have to treat or whether this too is an indefinite treatment. If they did not improve to the degree that you want, you could either consider a short course of systemic cortical steroids, then continue the biologic, or salvage surgery under biologic protection. Now, if they have no response, then what? Well, you could stop the biologic and change to surgery, or you could pick another biologic drug. And again, this is not proven, but typically what I recommend is the same as what I do with asthma. So if I'm using an IL-5 blocker, they didn't respond, then I'll switch to a different class, anti-IgE, anti-IL-4/13. And the same with the other ones. If Omalizumab doesn't work, I might switch to Dupi or Mepo. After 12 months, if they continue to have good improvements, then you just continue the biologic. Again, we don't know how long. If they don't, consider another biologic or surgery. It's a different way of looking at it. So again, if you have a patient with chronic rhinosinusitis with nasal polyps and they are not controlled with appropriate medical therapy, you can consider a biologic agent after you talk to the patient with shared decision-making, or possibly surgery. If they're not a surgical candidate, then you consider a biologic. If they complete the surgery and they're not controlled, you could always start the biologic at that point. Shared decision-making for biologics or other options always include a discussion of risk benefits. So the risk with biologics are pretty low. The benefits can be high, but again, we don't know how long patients have to be on a biologic, and they're expensive. So if you're going to treat someone for years with a drug that costs $25,000 plus per year, you better make sure that the patients are responding. With surgery, it's also expensive, and you have a relatively high recurrence rate, but in some people, they do much better after surgery. We do have other options like cortical steroid stent and, of course, intranasal cortical steroids. So all those things have to be considered when you're treating a patient. Now, as far as research needs for this disorder, we need better biomarkers that will tell us whether a patient is really a T2 high driven person. And better yet, wouldn't it be nice if we knew, yeah, you're a T2 high and you're more likely to respond to this biologic versus another, or surgery for that matter. We'll finally get some information about comparing between at least two biologics, but that's quite a few years away. We have to do cost-effective analysis because we don't know how long they have to be on a biologic. And the importance of comorbid conditions really comes into play because the cost effectiveness of a biologic could be a lot better if you're treating a patient with severe asthma that has exacerbations and their asthma and their polyps get better. Clearly, we also need longer-term safety studies, but at least in asthma, it looks good. So this is sort of a summary slide that looks at the pros and cons and the cost. And of course, intranasal corticosteroids are inexpensive, easy to use, should be used as first line. In my opinion, second line should be EDS with fluticasone, less expensive than the other options, less adverse events. Then consider surgery, an eluting stent, or a biologic. But all of those options tend to jack up the price more. And of course, the risk is greatest with surgery. The cost is greatest with biologics. So there's Bob again. And here we have your choices. Again, endoscopic surgery or biologic. And if he doesn't want to undergo surgery because of time missed from work or whatever, then that's when I'd really consider the biologic. And with him, he also had uncontrolled asthma, so it's not a bad choice. So in summary, patients with chronic rhinosinusitis with nasal polyps, very common, accounts for about 20% of that 11% of the population that has chronic rhinosinusitis. Common comorbidities include asthma and aspirin sensitivity. If you have nasal polyps, at least in the US, they tend to be more commonly to be type 2 driven. Medical management often shows short-term response, high failures, and that's when you look at surgery or biologics. So now we'll do some post-test. So now that we went through the talk, primary cytokines involved in type 2 inflammation, most common endotype is going to be, all right, it's going to be IL-4 and IL-13 and IL-5, type 2 inflammation. Type 1 inflammation, you would tend to see more of the other cytokines. IL-17, important for neutrophilia, and of course, interferon gamma and IL-12 tend to be more neutrophil driven as well. Next slide. Which biologic showed improvement in nasal polyp score by greater than 2 at both weeks 24 and 52? And Depilomab is correct. Next. Which is the most commonly observed treatment emergent adverse event? And we talked about that, so that is nasopharyngitis. Next. So here we have Mr. Brown again, 42-year-old, got nasal polyps, 12 months after surgery. These polyps have regrown, and he has some improvement, but he doesn't meet the criteria for adequate response. What would you do now? So again, there is probably no correct answer in this one. And if I look at all these, what would I do personally? Well, you know, I'm not an ENT surgeon, but I know some good ones. So I could refer him for repeat. But it's only been 12 months since he had surgery. If his asthma is not really doing that well along with this, I would really consider a biologic. If he's primarily having upper airway problems, then I might consider a cortical steroid eluting implantable stent, or I would use the fluticasone EDS device to see if that helps, even though that's not a choice. Next. So feeling discouraged, things are getting worse. He doesn't want to go through the pain and everything for surgery. So what would you do? And again, it's really the same thing. You're going to give him the appropriate options. In this case, you're probably going to go more towards a biologic because he doesn't want surgery. And if you do pick a biologic, you'll have to decide which of the 3 that are currently improved would you use. Depilomab is dosed every 2 weeks, might be able to be dosed every 4 after a period of time. Omalizumab is every 4, Mepo is every 4. Omalizumab, if it gets approved, is every 4, the first 3 doses, then every 8. Those decisions, if they're all home-based treatment, which they all are now, the interval time between injections could be important for some people, but I would always look at which one has the best effectiveness. Next. And that is it. So I'd be happy in the last few minutes if individuals have any. So no questions so far, but I think, a couple of important things. Here's one. Do you have any tips for clinicians to help ensure the cost of a biologic is covered by the patient's insurance? That's a good question, an important question. I think some Depending upon where you live, some companies really have it together as far as helping you with the appropriate paperwork to get them approved. And of course, again, depending upon where you live, how many hoops you have to jump through. And that would include, good documentation that the patient does have bilateral nasal polyps. Any documentation you could have that they have a T2 high phenotype might help. And then along with simple things like a nasal congestion score, SNOT 22, quality of life, all the things that might help you convince an insurance company that this is a needed agent to be used. If the patient has comorbid asthma, it tends to make it easier. Any other questions? All right. Well, if not, I'd like to thank everybody for spending the last hour. And my email is available. So if you have any other questions you think of later, please feel free to contact me. Thank you and good night.